This conference will now be recorded. This conference will now be recorded.
Okay. So good morning. So I just started recording. I'll start again. So today I'm going to discuss about abnormal uterine bleeding. Okay. So what is meant by this abnormal uterine bleeding? It's nothing but menorrhagia, metrorrhagia, and postmenopausal bleeding. So menorrhagia is nothing but an excessive bleeding at the time of menstruation. Metrorrhagia means irregular bleeding between the periods. The next most important thing is the postmenopausal bleeding. So if any woman comes with a postmenopausal bleeding, you should evaluate her immediately for an underlying lesion like endometrial hyperplasia or endometrial carcinoma or endometrial polyp or endometrial or some submucosal fibroid sitting just beneath the endometrium. Okay. So of these conditions, the most dreaded is the endometrial carcinoma. Okay, if someone comes with postmenopausal bleeding, you should suspect endometrial carcinoma and you should evaluate immediately. Okay, so what are the common causes for this abnormal uterine bleeding? I already told you, which include endometrial polyps, fibroids, endometrial hyperplasia, endometrial carcinoma, and of course endometritis, which we discussed in the last class. So what is meant by dysfunctional uterine bleeding? What is the difference between abnormal uterine bleeding and then dysfunctional uterine bleeding? So if you are not able to find an organic uterine lesion like polyp, fibroid, hyperplasia, okay, but patient complains of abnormal uterine bleeding, then it is called as a dysfunctional uterine bleeding. It's abnormal bleeding from the uterus in the absence of any organ, but a dysfunctional uterine bleeding. I'm just reading for your sake. Okay, so let us see the causes of this abnormal uterine bleeding in different ages of women. So in the pre-puberty, so the most common cause is the precocious puberty because of immature this hypothalamic pituitary thyroid ovarian axis. Okay, so the precocious puberty is the most common cause for abnormal uterine bleeding during the time of pre-puberty. Second is during the time of adolescence. The most important cause is anovulatory cycles. Okay, so there will be excess amount of estrogen, but there won't be any progesterone. This is one of the important reasons for the abnormal uterine bleeding during adolescence. Next is during the reproductive age. You should think of the complications of pregnancy. Of course, the anovulatory cycles and ovulatory dysfunctional bleeding. Okay, let us see the complications of pregnancy first, like abortion, trophoblastic disease, ectopic pregnancy, and our uterine proliferations like leiomyoma, endomyosis, polyps, endometrial hyperplasia, and carcinoma. Next is the anovulatory cycle. So anovulatory cycle we discussed. So here there will be excess amount of estrogen, so there won't be any progesterone because of anovulation. Next is ovulatory dysfunctional bleeding. So the ovulation has happened, but so there is an inadequate luteal phase. The luteum which was there, the corpus luteum which was there after ovulation is not secreting the required amount of progesterone. So because of that, there will be a inadequate secretory phase. So that is called as ovulatory dysfunctional bleeding. So whenever there is a decreased amount of progesterone, so obviously there will be intermittent uterine bleeding. Okay, so that is called leading to metrorrhagia. So you should think of inadequate luteal phase in those men. During the perimenopausal age, again the anovulatory cycles comes the first cause. Later on, irregular shedding because of insufficient amount of progesterone. Then proliferations like carcinoma, hyperplasia, and polyps. Again, in postmenopausal women. So I told you, so which is very one of the bleeding. Postmenopausal bleeding is one of the very dangerous uterine bleeding. So first you should think of endometrial carcinoma, then hyperplasia and polyps. So this is an important list you should remember for the abnormal uterine bleeding. So let us see what is meant by these anovulatory cycles. So this is because of the failure of ovulation. It is commonly seen in both at the age of adolescence and of course in the post perimenopausal age. So it is due to hypothalamic pituitary axis adrenal thyroid dysfunction. Okay, so this is a problem. So from hypothalamus, pituitary, thyroid, and adrenal, so there will be that axis will be disturbed. So there is a dysfunction in that. So because of that, there will be a failure of ovulation. Next, functional ovarian lesions, which is producing excess amount of estrogen. So, like polycystic ovarian disease, like thecoma, those conditions. Next, malnutrition. Okay, so malnutrition. So some may be obese or some are ill-nourished. They also may result in anovulatory cycles. Then debilitating disease like malignancy or some other reason. Severe physical or emotional stress, they also may result in anovulatory cycles. Okay, so please do remember all these things. Ovulatory failure results in an excess of estrogen related to the progesterone. Thus, the endometrium goes through a proliferative phase, and that is not followed by a normal secretory phase. The endometrial glands may develop mild cystic changes or appear disordered. So this is how a disordered proliferative endometrium looks. Actually, this 3-4 slides, but I want to cover it again because it's such an important topic, and every woman, most of the women, 90 out of 100 women comes with complaint to gynecopy. Okay, and that's why I want to cover this topic again. So if you see the microscopically, the woman coming with this disordered proliferative endometrium, you can see many tubular appearing like a proliferative endometrial gland, but they are showing cystic dilatation and lumen may filled with some sort of secretion. And stroma is also showing areas of edema. So this is nothing but an anovulatory or disordered endometrium containing dilated glands. Next, inadequate luteal phase. So I already told you the corpus luteum which secretes progesterone may fail to mature normally or may regress prematurely, leading to a relative lack of progesterone. Okay, so what happens is under these circumstances, the endometrium fails to show the expected secretory forms. It results in again the abnormal. Next, contraceptive induced bleeding. The contraceptive induced bleeding. Okay, now actually the latest contraceptives are not causing much problem, but in earlier years they used to use the synthetic estrogens and synthetic progesterones. They used to cause irregular return bleeding because of intake of oral contraceptives. Next, endomyomasfibroids disorders like chronic endometritis. So we discussed the list of the organisms causing endometritis in the last session. All STDs, sexually transmitted diseases. All these infections will cause endometritis. Next, endometrial polyps. Sometimes endometrium will throw in the form of polyp. Then submucosal leiomyomas. So they also may cause the inadequate or abnormal uterine bleeding. So let us discuss about endometrial hyperplasia. So it is due to because of excess amount of estrogen related to the progesterone and can induce exaggerated endometrial proliferation, which is an important precursor of endometrial carcinoma. So what are the potential causes of estrogen excess, which include failure of ovulation, as in perimenopause, or prolonged administration of estrogen steroids without counterbalance in progesterone, and estrogen producing ovarian lesions like polycystic ovary disease, granulosa thickness tumors of the ovary. These are the conditions in which there will be excess amount of estrogen. Again, the common cause of estrogen excess is obesity, which most of us lack actually. So what happens in obesity is, so the fat which is there in the body will convert into the estrogens. So it results in excess amount of estrogen, again causing endometrial hyperplasia. Okay, so again there are certain differences in endometrial hyperplasia in like simple and complex. Again, complex with and without ATPA. Okay, so the severity of hyperplasia is correlated with the level and duration of estrogen excess and is classified based on the architectural clouding, which is called as simple versus complex, and presence or absence of cytologic ATP. Okay, the risk of developing carcinoma is related to the presence of cellular. So the more is the ATPA, there is a high chance of transforming it into a carcinoma. Then complex hyperplasia without cellular ATPA carries a low risk for progression to endometrial carcinoma. Whereas complex hyperplasia with cellular ATP associated with much higher risk. So that is around 20 to 50%. That's why we should recognize this endometrial hyperplasias, and we should convince the patient to undergo for dilatation and curettage. This is how a complex hyperplasia without ATPA looks. You can see the nests of closely packed glands. I mean, if you see the gland to stroma ratio is increased, the glands are crowded. So there is no at area, there is no stroma in between, and the glands are like fused and they form like cribriform structures. Okay, the very important thing you should identify microscopically. So as an MBBS student, you may not understand this, but as a pathologist, okay, so we give a lot of importance for these things. Next is the complex hyperplasia with atypia, seen as glandular crowding and cellular. You can see there is definitely there is a cellular and of course the nuclear crowding, and there is a atypia. In this photograph it is not much clear, but you can identify there is a nuclear loss of nuclear polarity even, and the pencil shaped nuclei is converted into a round vesicular nucleus central prominent nuclei. So there is a cellular atypia and there is a overcrowding of the glands. So when there is a overcrowding of the glands with an association with cellular atypia, then is called as a complex hyperplasia with atypia. Okay, now actually this was called as endometrial intraepithelial neoplasia at the latest, as per the latest WHO terminology. This is called as endometrial intraepithelial neoplasia. Okay, so whereas the previous one was called as endometrial hyperplasia without atypia, now the latest WHO says endometrial hyperplasia without atypia. Now it is not classified as simple or complex. This is the Robbins classification. I am just projecting here because you're all undergraduate students, but if I teach same thing to the postgraduates, I teach differently. So I teach as per the WHO guidelines. Okay, so the latest WHO says this complex hyperplasia without atypia as endometrial hyperplasia without atypia, whereas the complex hyperplasia with atypia, the WHO says as endometrial intraepithelial neoplasia. Okay, so these are the things you should, the advanced things that you should know, because so when you're writing MCQ, when you're writing MD or MS entrance, you should know these things. Next is that the one more important point I forgot to mention in this slide is acquisition of PTEN mutations. Acquisition of PTEN mutations is believed to be one of the several precursor thing for transformation of hyperplasia to endometrial carcinoma. This is a very important thing. So this acquisition of PTEN mutations in this endometrial glands is a very so important thing. So once they acquire that PTEN mutation in those glands, in those things, what happens is that the hyperplasia will transform into endometrial carcinoma. Next we discuss about endometrial carcinoma. So it appears generally between the age of 55 and 65 years and is uncommon before the age 40. So on the basis of clinical and molecular data, so two major types of endometrial carcinoma are recognized, which include endometrioid type, which is accounting for 80% of cases, and the serous type, which is accounting for 15% of the cases. Even though the serous type accounts for 15% of the cases, so it presents with advanced disease. That's why the serous is much more dangerous than endometrioid type. So let us see what are the risk factors for endometrioid carcinoma, which include obesity. That's why obesity is not at all good for anybody. Obesity is not at all good. So, okay, we should eat whatever, only whatever we require. Okay, so because what is happening is because of this lockdown and staying a long period of time at home, what we are eating a little bit more, I think. Okay, so we should eat to the calories what we require. Next, diabetes, hypertension, infertility, and exposure to unopposed estrogen. So these are the very important risk factors. Like one is obesity, second is diabetes, third is hypertension, fourth is infertility, and fifth is exposure to unopposed estrogen, like usage of oral contraceptive pills. So these are the risk factors for endometrial carcinoma. So why we are calling this as endometrial carcinoma? Because the tumor, the glands that resemble like a normal endometrial gland. That's why we are calling it endometrial carcinoma. I will show you the photograph later on. So let us see the pathogenesis. Why this endometrial carcinoma is happening in a particular group of women. So one I already told you the risk factors like obesity. Okay, so diabetes, hypertension, so infertility, all these things, exposure to unopposed. So is usually associated with the estrogen axis and endometrial hyperplasia. Okay, So in the previous slides, we discussed endometrial hyperplasia. If it acquires the PTEN mutation, it will transform into endometrial carcinoma. Okay. So before that, the early molecular changes, what happens is the inactivation of the DNA mismatch repair genes. Okay. So this we discussed when I discussed the forever batch during the, in the third semester, in the early of the third semester. So when I am discussing about cell cycle, I taught you the cell cycle. So I told you about how the cell divides and the different phases of cell cycle. And so, of course, if some mutation happens, what happens? So suppose mutation happens, what will happen is cell division will get arrested at that point of time, and cell will give certain time for that mutation to get repaired by the help of this DNA mismatch repair genes. Suppose if that particular mutated DNA was not repaired properly, what happens is that cell will undergo apoptosis. This I told you very clearly when I am discussing about the apoptosis and cell cycle in the beginning of your second year. Okay, so one is there is a defect in the DNA mismatch repair genes. What happens is because of that, the DNA won't get repaired properly. So once the DNA won't get repaired properly, what happens? The mutated DNA will enter into a cell cycle and it will multiply into n number. So that is the first insult, and second one is the PTEN. So inactivation of the PTEN tumor suppressor gene again. So there are certain tumor suppressor genes are there in our body like P53, RB gene, PTEN gene. What happens is they suppress the tumor. So suppose they themselves got mutated, like here PTEN is getting mutated. It's in this endometrial carcinoma. What happens is there is nobody to control them. So what happens is the cells will multiply, the mutated DNA will multiply in n number and it will result in formation of a tumor. Okay, so here it is because of the mutation of DNA mismatch repair and PTEN. What happens is we are getting endometrial carcinoma. Okay, there is a syndrome in association with PTEN that is called Foden syndrome. So these are very much at higher risk for other epithelial cancers like breast and of course ovary, those things. Okay, so please remember that. So next is the serious carcinoma of the endometrium arises in older women and usually associated with the endometrial atrophy. Okay, so here I told you about P53. P53 also is a tumor suppressor. So what happens in serious type of endometrial carcinoma is there is a mutation of the P53 gene. So because of that, there is a serous carcinoma. There's because of mutation of the PTEN, there is a endometrial carcinoma. So please do remember these two things. Coming to the morphology, endometrial carcinomas closely resemble normal endometrium and may be exophytic or infiltrative. They include a range of histologic types, including those showing mucinous, tubal, and squamous. Tumors originate in the mucosa and may infiltrate the myometrium and enter vascular spaces. They may also metastasize to regional lymph nodes. And endometrial carcinomas are grade 1 to 3 based on the degree of differentiation. Like, so if there is a more amount of solid area, it will become grade 3. If there is more amount of glandular area, then it is a grade 1. Okay. Next is serous carcinomas form small tufts and papillae rather than glands seen in endometrial carcinoma, and they exhibit much greater cytologic atypia, and they behave aggressively, and thus are by definition they are called as high-grade carcinomas. And in IHC reveals high levels of P53 in the serous carcinoma, a finding that correlates with the presence of P53 mutation. This we discussed already. Okay, this is how an endometrial carcinoma looks like. So you can see the closely packed glandular structures forming cribriform spaces, and if you, on the high power, if you see, these glands are showing the nuclear atypia, enlarged vesicular nuclei. So you can see, open chromatin. So all those things. And if this is a case of serous carcinoma, you can see papillary tufts with the nuclear atypia, and this is the P53 because of the mutation. Because of this mutation, there is a serous carcinoma. The P53 mutation is resulting in serous carcinoma. So the mutant P53 can be detected by using immunohistochemistry. Next is the clinical course. Endometrial carcinomas usually manifest with leukorrhea and irregular bleeding, often in postmenopausal women. Leukorrhea is nothing but a white discharge, and of course irregular bleeding. I already told you. So whenever a postmenopausal comes with an irregular bleeding, So I mean, postmenopausal bleeding. I mean, it's obviously should think about endometrial carcinoma. So these tumors sometimes they usually confine to the uterus. So uterus will get enlarged initially. Later on, what happens is if the tumor invades the parametrium and of course the serosal aspect of the uterus, what happens is the uterus will be fixed to the adjacent structures. So uterus will be enlarged and uterus will be fixed to the adjacent structures. And later on, they will go under metastasize. And if treated early, the prognosis is very good. If they don't treat early, what happens is they disseminate to regional nodes and of course to the distant sites. The prognosis with serous carcinoma is strongly dependent on operative staging, and what is important here is what I want to stress here is peritoneal washings. So whenever you suspect a case of endometrial carcinoma or whenever you are operating a case of endometrial carcinoma, so never ever forget to take a peritoneal washings. It's very, very, very important. Suppose if there is a tumor within the peritoneal washings, so the prognosis will be very bad. Actually, it will become a stage 4 disease. Okay, so this is what I want to stress you. Tomorrow, some of you may become a good surgeons or oncosurgeons. Okay, so you should not forget this point. Next is endometrial benign condition like endometrial polyps. So they may be sessile or may be pedunculated, may range from 0.5 to 3 centimeter. So what happens is the large polyps will project into the endometrial cavity, and so on histological examination, what you will find is, so the endometrial glands resembles that of a basalis endometrial, resembles the basal endometrium, and apart from the endometrium, what is important is the presence of these thick muscular arteries. Unless you see these muscular arteries within the, just saying, you can't call this as polyp. Sometimes endometrium itself will throw in the form of a polyp. So, but you cannot make it as call as a polyp. You should see this muscular arteries. Then only you should call it as a polyp. Then the stromal cells are monoclonal, often with the rearrangement in the chromosome, short arm of the chromosome and the reason too. Okay, so this is the reason why some of the women will get endometrial polyps, because there are rearrangements in the chromosome 6. Next is the uterine leiomyomas, otherwise called as fibroids. So benign tumors that arise from the smooth muscle cells in the myometrium. The most common benign tumor in females, affecting 30 to 50% of monofibroid phase. So here the rearrangements occur in the chromosome 6 and 12. Estrogens and possibly oral contraceptives stimulate the growth of leiomyomas. The most frequent presenting sign is menorrhagia, with or without atresia, and the pelvic mass are may be detected as a cause of infertility. Okay, so we already discussed what is menorrhagia, what is metrorrhagia, and apart from the irregular menstrual bleeding, what happens is they also present as with a pelvic mass. Okay, or sometimes this submucosal fibroids which were there. So what happens is they won't allow the implantation. They won't allow the implantation of the blastocyst. What happens is it results in again infertility. That's why you should remember these fibroids are one of the reasons for infertility. This is how it looks. You can see multiple fibroids ranging from 5 millimeter to almost 5 centimeter fibroids. You can see this is a submucosal fibroid just sitting beneath the endometrium, and this is an intramural fibroid within the myometrium, and some of the fibroids will be subserosal. And the subserosal fibroids, what happens is sometime in due course of time, they get dislodged from the uterus and they get blood supply from elsewhere, like broad ligament or something else. So then we call them as parasitic leiomyomas. Next is leiomyosarcoma. The leiomyosarcoma usually won't arise from the leiomyomas. Actually, they arise de novo from the mesenchymal cells of the myometrium, not from the pre-existing leiomyomas. And solitary, most often occur in postmenopausal women. Again, so if a new woman comes with a postmenopausal bleeding, again, it's invariably some sort of malignancy. You should please keep in mind. Okay, so what is the criteria? What is the difference between leiomyoma and leiomyosarcoma? In leiomyoma, you see the spindle cells. Okay, they appear cigar shaped, and you won't find any nuclear atypia. or mitotic activity or necrosis. Whereas in a leiomyosarcoma, if you see the lot of nuclear atypia, and you can see abnormal or atypical mitotic figures. You can see this is one atypical mitotic figure, here one is atypical mitotic figure, and you will find necrosis. So these are the three important, very important criteria to call as leiomyosarcoma. And there is one condition called stump. So in cricket we usually say stumped. Okay. So there is one entity called stump between leiomyoma and leiomyosarcoma that is called as smooth muscle tumor of uncertain malignant potential. Smooth muscle tumor of uncertain malignant. Okay. So when the tumors either they don't fit into either leiomyoma or leiomyosarcoma, because they will have atypia or mitotic, but they won't have necrosis, or they will have necrosis when they will have a little atypia. I mean, like that. So out of two criteria they will have. So then we call them as smooth muscle tumor of uncertain malignant potential. Okay. We find all the three like necrosis, atypia, mitotic activity, and so you can call it as a leiomyosarcoma. Next. So we covered the vulva, vagina, cervix, uterus. So now we are coming to the fallopian tubes. Okay. So what is the most common complaint you come across with the fallopian tubes is salpingitis. So most of them when they complain and say the low abdominal pelvic. Okay. The reason for this pelvic pain is salpingitis. So it is usually a component of pelvic inflammatory disease. It results in scarring of the fallopian tube lining, increasing the risk of tubal ectopic pregnancy and of course sterility. Okay. So both the tubules are blocked, what happens? It results in sterility. Okay. That's why so you should maintain a very good hygiene, especially because of short urethra in women. So woman will have a short urethra. There is every high risk for what happens is getting infection in the urethra. That infection in the urethra will extend into the vagina, and of course into the both cystitis, bladder, ureter, bladder, kidney. So the infection might either go into the reproductive system or into the urinary system. So that's why you should maintain an utmost hygiene. So the most common infectious agent in women is you all know that gonococcus. Okay, the Neisseria gonorrhea, so which causes the sexually transmitted disease. Apart from gonococcal infections, you will also have other like apart from gonococcus, you will also have other infectious organisms like chlamydia, mycoplasma, and coliforms like E. coli. And in the postpartum setting, you may also have encountered streptococci in the wards, hospital wards. So they can penetrate the wall of the tubes and give rise to the bloodborne infections, seeding of the meninges, joint spaces, and sometimes even the heart valve. That's why very important. That's why this postpartum period is very crucial. You should maintain very utmost important hygiene. Okay, so you should. That's the reason why I'm stressing so much on hygiene. So initially it may be only in the urinary tract or in the reproductive system or genital tract. Later on, that will enter into the systemically, resulting in meningitis and joint. Recently, one case I have seen infection in the joint spaces. Okay. Next, sometimes they may even to go into streptococci may cause rheumatic heart disease. Everybody knows this. Okay. That's why you should be very careful. Next, primary adenocarcinoma of the fallopian tube may be of serious because of DRCM BRCA mutations or endometritis class type. Okay, so they usually manifest at an advanced age with a long momentum because you know that the femoral end of the fallopian tube is in continuum with the peritoneal cavity. That's why the carcinoma of the fallopian tube will invariably will enter into the momentum or the peritoneal cavity. That's why again here the peritoneal washing, taking a peritoneal washing during the time of surgery is very crucial, and it is imperative. This is the gross photograph of you can see a case of pelvic inflammatory disease. You can see bilateral, both tubes are involved here. Both tubes are reddish, and ovary also, some portion of the ovary is also showing this erythematous, and this side ovary and fallopian tube both are involved and they're forming a mass. So this is called as tubovarian abscess. Okay, So this is how it looks grossly a case of pelvic inflammatory disease. You can see both tubes, and of course one side of ovary they got distended and filled with pus. Now we've cleared even the fallopian tubes, the lesions of the fallopian tube. Now we entered into the big one, that's ovary. Okay, we have two ovaries. So everybody, everyone will have two ovaries. You all know that. Okay, so what is there in the ovaries? I mean, the follicles, they mature. The primordial follicles will mature into a mature follicle, and that during the time of ovulation, what happens is that mature follicle will rupture, and it will release the ova, and that ova will be taken by the fallopian tube, and the ova will go into the isthmus, and of course, when the fertilization will occur within the fallopian tube, the second portion of the fallopian tube, and after fertilization, after 3-4 days, that blastocyst, that embryo will go and sit in the uterine cavity. Then it is called as implant. You all know that even during the time of embryology, when you are reading first entities, you all know that. You might have studied. So these follicles, when during the different stages of maturation, what happens is they form a cyst, ranging from 1 to 1.5 centimeter. Okay. So they form cyst either because of unruptured Graafian follicles or follicles that have ruptured and become immediately sealed. So they also form a cyst. So what they accumulate is they usually accumulate a serous fluid, and when they become around 4 to 5 centimeter, what will happen? They form a palpable pelvic masses, and they also present with pelvic pain. Okay, so this also you should remember. Okay, so even they are small, they are usually lined by these granular cells or luteal cells, but as the fluid accumulates, the pressure will cause atrophy of these cells. So sometimes this will cause a rupture and produce intraperitoneal bleeding and peritoneal symptoms like acute abdomen. This is called as Mittel's match. What is meant by Mittel's? We should also remember one point, it's called Mittel's match. So during the time of ovulation, what happens is, along with ova, some sort of blood will be released into the peritoneal cavity, resulting in acute pain. Okay, so that is called as Mittel's match. Okay, so during my internship, I have seen one of my junior coming with Mittel's match to the emergency. Emergency recasement. Okay, so we should know about these things. We should not become panic like for situations like Mittel's match. So it usually occurs that during time of ovulation. So along with the ova, which is released into the peritoneal cavity, what happens is there will be a release of some sort of blood will be released into the peritoneum, and that will cause the peritoneal symptoms like acute pain abdomen. And so we should not be panic. You should take some muscle relaxant, then it will subside. You don't need much attention is not required for that. Next and most important thing is this polycystic ovarian disease. Okay, so this is one of the leading cause for primary infertility. Most of them is always called as Steele-Leventhal syndrome. So it's a disorder in which multiple cystic follicles in the ovaries produce excess androgens and estrogens. Whenever there are excess androgens and estrogens, what happens is they inhibit the secretion of follicular stimulating hormone by the pituitary through the hypothalamus. So what happens is there won't be any secretory phase. So only excess amount of estrogen will be there. Once it inhibits the follicular stimulating hormone, what happens? There will be no ovulation. This is called as anovulatory cycle. This is what we discussed before. Excess estrogen will cause anovulatory cycles. Okay, because of so negative feedback to the pituitary. So pituitary won't release the FSH. So through the hypothalamus. Okay, so you all know that endocrinology, the chapter of endocrinology is also covered. So it usually comes to attention after menarche in teenage girls or young adults who present with oligomenorrhea. Okay, so that is what is when oligomenorrhea, decreased menstrual bleeding. Next is hirsutism. So usually the woman won't have hair on the face, but so this woman with polycystic ovarian disease will have a hair on the face. It's called as hirsutism. Next, infertility. So whenever there is no, there is no ovulation, there is no chance of fertility. Okay, fertilization. So it results in what? Infertility and sometimes obesity. Not sometimes, many times. I have in my personal experience, many times obesity is the leading cause for this polycystic ovarian disease. Okay, so because of obesity, what happens is the excess amount of fat which is there in the body will be converted into estrogens. Okay, what is estrogen is doing? You all know that estrogen is blocking the FSH release from nature. Okay, so once if there is no FSH, there will be no ovulation. There is no ovulation, there is no fertilization. There is no fertilization, it results in infertility. So this is how it looks. So you see a normal ovary, how it looks. It's simple. Okay, so what happens in polycystic ovarian disease is it will become enlarged in size, and this is a normal sequence. The primordial follicle will mature into primary, then secondary follicle, then mature follicle, and it will release the ova. That ova will be taken away by the fimbrial end of the fallopian tube, and it will enter into the fallopian tube, and in the ampulla, the second part of the fallopian tube is called as ampulla, in which the fertilization normally happens. Okay, so what happens in this polycystic ovarian disease is multiple the follicles, the multiple follicles will be there. They will become immature. They will be immature because of there is no FSH. The estrogen is continuously stimulating them, and they become a cyst. Because if there is no FSH, there is no release of ova. Because of that, they will become a multiple immature follicles. Okay, so the ovaries are usually twice the normal size in PCOD, gray white with a smooth outer cortex and studded with subcortical cysts ranging from 0.5 to 1 cm in diameter grossly. On histology examination reveals a thickened fibrotic ovarian capsule overlying innumerable cystic follicles and by granular cells with a hyperplastic lutein thickened. Okay, so these are the findings you expect in patients with polycystic ovary. That's all about polycystic ovary. This is the leading cause for infertility in India. So please do remember this. This is one of the most leading cause. The next is the. So I will just start. I will give just brief introduction for you. The next session, next class, it's about the lesions of the ovary. So ovary will have the surface epithelium. Okay, from the surface epithelium we get the tumors accounting for 65 to 70% of the tumors, and of course 90% of the malignant tumors arise from the surface epithelium, and they include serous tumors, mucinous tumors, endometrial tumor, clear cell tumor, Brunner tumor, and cystadenofibroma. Okay, the serous is a benign, it could be borderline or malignant. Again, mucinous benign, borderline or malignant. Endometrial usually is malignant. Okay, so depending upon the type of the type it will mature, so it results in different types of carcinoma. From the germ cells also we get a lot of tumors accounting for 15-20% of the cases. First is surface epithelial accounting for 70%. Second is germ cell 15-20%. Then the proportion of malignancy is around 3 to 5%, and it is seen between 0 to 25 years. Whereas surface epithelial tumors are seen beyond 20 years. The germ cell tumors include teratoma, dysgerminoma, endodermal sinus and choriocarcinoma. Next entity is the sex card stromal tumors, which include around 5 to 10% of the cases. The malignant tumors accounts for 2 to 3% of cases. All ages are affected. The sex card stromal tumors include fibroma, granulosa theca cell tumor, and Sertoli Leydig cell tumors. Next, metastasis tumors, the tumors from the stomach or elsewhere. So they will undergo usually by a peritoneal route. They will metastasize to the ovaries, and they are accounting for around 5% of the cases. Okay, this is the brief introduction. I'm going to discuss in the next sessions. Maybe 1 or 2 classes. I'm going to cover all the lesions of the surface epithelial tumors, germ cell, and sex card stromal, and of course the most important is the Krukenberg tumor, which is nothing but the bilateral metastatic ovarian tumor originating from the primary from the carcinoma stomach. Okay, so I'm going to discuss all these things in the next coming classes. That's all for today. Thank you so much for your participation. If there are any doubts, you can ask me. If none, I will stop.
This conference will now be recorded.
If any doubts, you can ask me any doubts you have. If none of the doubts are there, then you can chart in the this thing also. So you can any doubt you have, you can post in the WhatsApp group, and I'm going to update the PowerPoint what I have discussed today in our WhatsApp group. If any doubts, you can just you can chat or you can discuss in the group. Okay, so I'm going to end the session here. Thank you so much for your cooperation. I thank both you and of course the organization for providing all this facility to reach you. Thank you so much. Thank you everybody.